Good evening, everybody, and welcome to the Pacific Spine and Pain Society Spinal and Pelvis Biomechanics webinar. It is my pleasure to be with you tonight, and for those of you who are on, you're definitely interested in learning about biomechanics. A little bit of history about the origins of Pacific Spine and Pain Society. We started this society in 2020, which was quite a year, as we all know. We thought that it would be wonderful to create some collaboration between interventional pain and spine surgery because of a lot of the new technologies that were coming about. And we knew that there was going to be a lot of discussion, debate, et cetera, and even some, frankly, animosity in how some of these things were being done and who was doing what and what was being covered and what was the reimbursement and all of these issues. And rather than duke it out, whether in public or by emails or on LinkedIn or on social media, we felt like the society should really be the forum for these discussions and debates. And so in the end of 2021, 8 different societies, primarily orthopedic and neurosurgery societies, made a position statement on non-surgery trained physicians doing arthrodesis of the spine. And I think that that statement's very important for all of us. You could be offended by it, you could be pro it, but the important points from that position statement were that, number one, the concerns from many of those who signed off on it were that individuals doing these procedures might not understand, number one, the biomechanics of the spine and spinal anatomy, and then secondly, that those who are doing these procedures might not be able to handle complications. So I think that's really important. I think everyone, no matter what your discipline is, what your background is, should be very aware and understanding of all of these issues. And we've had a number of non-surgery interventionalists state that this society should make a statement rebutting that. And I think it's better not to fight and rather educate. So tonight's webinar is really about that, educating all of us on biomechanics. And I'm really fortunate to have my great friends and colleagues in different specialties who are in orthopedic spine surgery and neurosurgery and doing a lot of spine surgery as well. And these guys, Neil and Michael, are very collaborative. They work really well with the pain physicians in their community, and they've been great hosts in educating everyone about the things that they do. So I think that the takeaway messages from tonight's webinar is really going to be about, number one, talking about some of the hot button issues like sacroiliac joint fusion, interspinous fusion, which I'm sure many of you are anticipating we'll talk about, but also more importantly, when to identify these patients with unstable biomechanics and when to refer to a surgeon. I think that there is this idea that pain physicians may hold on to patients who may be good surgical candidates, quite frankly, and it's probably a lack of awareness or understanding or education on when those patients should be referred. So I hope this webinar sort of helps everyone help our patients, because the more that everyone knows about the other side, the better off our communities and our patients will be. So I'm going to introduce myself, and then I'll have Neil and Michael introduce themselves. So my name is Ramo Naidu. I'm an anesthesiologist, interventional pain physician. Graduated at the University of Washington for my residency in anesthesiology, and then University of California, San Francisco for my fellowship. I stayed on at UCSF for 6 years on faculty, and then went into private practice, joining a multi-specialty orthopedic practice, private practice. And a lot of these discussions have really flourished. And I've learned a great deal from the spine surgeons that I work with, and understanding, when or when not to do certain procedures. Neil, I'll hand it off to you for your intro.
Thanks, Ramo. My name's Neil Schonard. I'm a senior spine surgeon. As you can tell, everybody else is younger here. And I was trained at UCSF in orthopedics, went to Rothman for a fellowship, and have been out in private practice. In private practice, I've led physicians in the development of registries that measure the benefits of spine surgery, and registries that measure the benefits of interventional pain procedures in osteoporotic fractures. I'm presently in private practice in my community and work with Ramo and others in a collaborative fashion. You'll see the things that I am going to address tonight are basically designed to give us all a common language that we all share the definitions of, and we all share the understandings for, and to recognize green light, yellow light, and red light scenarios that highlight a need to speak with our colleagues about the patient and their condition. Michael?
Thank you, guys. Michael Dorsey. I am a neurosurgeon with UCLA up in Ventura County, California. I actually went the opposite career trajectory than Ramo. I left academics after training at Hopkins and UCLA and went 8 years in private practice, grinding and fusing and operating like crazy, and then took a step back, and around 2020 decided to become more intellectual in my pursuits and took a job back with UCLA, directing their community neurosurgery. So my practice focuses now on minimally invasive spine surgery, and my interests are motion preservation, as well as really academically bridging this gap between our two specialties. And a lot of the fine interactions I've had over the last 2 or 3 years through PSPS have been just that, the interactions and trying to up both of our games so that we can collaborate and provide better patient care.
Thank you, guys. So our agenda is as follows. Next slide. And we're really going to take tonight a 30,000-foot level of biomechanics, and we really broke it down into 3 basic sections of the spine, starting off with the pelvis and the sacroiliac joints, because again, that's been a hot button topic. Then we'll talk about lumbar fusion, the different types of fusion, measuring foundational aspects such as sagittal balance and Cobb angles. And then we'll talk about cervical fusion with the advent of cervical disc replacement and some more of the data and the inclusion-exclusion criteria. I think it's important for the non-surgery trained physicians on this webinar to understand, who's appropriate for which procedure. And then we'll close out with some questions and answers. And so during this webinar, feel free to ask any questions along the way. After each session, we will have a time of about 5 minutes for any questions and answers. I have some that are strummed up, but would look forward to hearing what you guys have to ask. Dr. Schauner gave a great lecture regarding the economy of the human skeleton at Seattle Science Foundation a few years ago, and it's stuck with me ever since, and that's why I asked him to speak tonight. So I hope you enjoy the next 10 minutes with Dr. Schauner. Thanks.
Thanks, Ramo. So if we could go to the next slide, we'll start off with this cone of economy. Dr. Dubosset in France came up with this as part of he and Cottrell's work pioneering the advanced understanding of deformity associated with scoliosis. But the history of this actually dates back more than 500 years. And here you're seeing Andreas Vesalius's absolutely stunning lithograph. This lithograph was obviously done in Titian's studio in Venice because you see the influence of perspective that arose in the Renaissance. And actually, this is a brilliant lithograph. What you see is the person is their skeleton, and Vesalius did more for the skeleton. He rewrote what Galen originally did 1,300 years earlier. But what you see on this skeleton is what we're going to talk about tonight. You see the cervical spine is hyperlordotic so that the patient can tilt their head up enough to see the horizon, which has been magnified in this view, where you see the trees are remarkably miniaturized and the skeleton is maximized in the brilliant use of perspective. But you also see the thoracic spine is flat and the lumbar spine is flat and the pelvis is vertical. These are all the deformities which we're going to describe. And if you drop the plumb line from the C7 vertebra, it would pass well in front of the pelvis. You're going to see that later on in the measurement of the sagittal vertical axis. And you can see that if you drop the plumb line on the back side, the patient is scoliotic and the line passes to the right of the sacrum. You also see the hips are flexed, the knees are flexed, and the ankles are flexed. So this individual has an extraordinary energy requirement just to stand and walk. And this was all depicted 500 years before we began to study what the science of this is. The science of this is two-plane deformity measurement. in a balanced sagittal plane. So you're looking on the left of the slide and you see the profile that Vesalius was showing you at a 45-degree angle. The profile shows the line passes from C7 into the posterior superior aspect of the end plate of S1. Or to say it another way, the skull is directly over the pelvis, the shoulders are directly over the hip, and it takes a minimum amount of energy to walk down the street. When the sagittal vertical axis shifts in front, it becomes positive. That's the red line on the left, and that's what Vesalius was showing, a remarkably positive sagittal balance. And on the coronal balance, these three depictions on the right, you're looking at scoliotic curves. And when the scoliosis curve still has a plumb line from C7 dropping through the middle of the gluteal fold, the person's shoulders and head are on top of the pelvis. There is energy economy. When it shifts off to either side, there isn't economy, and the deformity and imbalance occur. So rather than estimate and guesstimate, and this is taken from Jeff Mast's book on preoperative planning, what we want to do is we want to bring biomechanics, biology, and artistry into play in fixing these deformities. Next slide, please. By understanding their biomechanics. So here's one of Jeff's depictions. He was an AO fellow in trauma, and what he did is he took tracing paper. He outlined each of the fragments. He took the normal femur from the opposite side, flipped it over, used it as a template for what the normal femur would have looked like minutes before this trauma, assembled the individual fragments so that he could identify them one at a time. Next slide. And then drew up a preoperative plan by placing the individual hand-drawn tracings back into proper order, superimposed on the normal tracing of the normal femur. He added an implant, he added a series of steps in which to assemble this, the biomechanical forces which would be added to assemble it, and finally he put them in sequence to how to, so you can see from a preoperative planning perspective how you can make all of these biomechanical decisions conform and the biology get restored. Next slide, please. And what you see is the long-term outcome of this is a restoration of the physiology of the extremity. The bony architecture has been restored. The preoperative plan has worked perfectly. And for those of us in spine, this is a classic example of taking artistry, biomechanics, and biology and making it work for the patient. Next slide, please. Putting the principles into practice. And in order to do that, you have to share in an understanding of what are the terms that you use in speaking with your colleagues. The next topic we're going to go into is going to be the individual measurements. So when you look at these individual measurements, you can actually see by looking at this stick figure, you can see what Vesalius had drawn. He had drawn a hyperlordotic cervical spine so the deformed individual could tilt their head up enough to see the horizon. Their thoracic spine had become flattened, their lumbar spine had become flattened, and the pelvis, with the red angles drawn on it here, had tilted vertically. This is a term in biomechanics called retroversion of the pelvis, but remembering it as the pelvis tilting vertically, it imposes a flat back on the lumbar spine, and these corrective measures include flexing the hips just to stand, flexing the knees just to walk, and dorsiflecting the ankles. So this becomes a very uneconomical posture and walking. Next slide, please. So this individual is out of spinopelvic balance. When you look at the individual measures that are most important, they are three. The pelvic incidence, which is PI on this diagram, a vertical line drawn to the center of the superior end plate of S1 establishes the center point of the S1 superior end plate. And if you drop a line from that point to the head of the femur, or as you see on the X-ray diagram, a line between the heads of both of the femurs, that is your pelvic incidence. a line drawn from that same center of S1, that's point A on the diagram, to the center of the femoral head and then going directly vertical up toward the skull is your pelvic tilt. And as this pelvis tilts forward, the pelvic tilt becomes larger. So as the pelvis becomes more vertical, that pelvic tilt line and angle become larger, and the deformity and the economy of walking diminish. The other line that is critically important is on the X-ray. It's a line from the C7 vertebra through the posterior superior point of the sacrum, which is line B, point B on the drawing, and that's the sagittal vertical axis. So the X-ray is showing a 35-year-old woman with a normal balanced spine. The diagram is showing how to draw these lines, the angle of the pelvic tilt, the angle of the pelvic incidence, and the sagittal vertical axis. Those three metrics are critically important for discussing with your colleagues. The X-ray on the left shows these, and the diagrams show the definition of each of these. The pelvic incidence taken from the midpoint of a perpendicular of the superior end plate of S1 down to the femoral heads, a vertical line from that same center of the femoral head going up, that's the pelvic tilt. And notice when you look at the diagrams on the right that the normal pelvis in the middle diagram, as the sacrum becomes more vertical, your pelvic tilt increases, your sacral inclination flattens, and your pelvic incidence increases as your lumbar lordosis flattens. And so using these parameters and these definitions of a vertically tilted pelvis, an increase in the pelvic incidence, and a mismatch of the relationship of the lumbar spine, the lumbar lordosis, to the pelvic incidence, allow you to describe a patient who is out of balance. Now we'll look at, as we all try to get familiar with these, we'll look at effects that we have on the SI joints when fusion is done. Ramo, can I pass this back to you for a moment?
Yeah, thanks, Neil. So that was wonderful. So I think it's really important for everyone to understand how those angles are measured, especially important for lumbosacral fusion or measuring those different angles for a patient that's walking in with these imbalances. Kind of shifting gears a little bit, we're talking about the pelvis, but we're going to talk more into the sacroiliac joints because a number of providers on this webinar do perform sacroiliac joint fusion. And it's well known that there's not a large degree of range of motion with this particular joint. Estimates are anywhere from 3 to 4 degrees in someone who doesn't have major ligamentous laxity. So the question for both Michael and Neil, what impact does fusion of the sacroiliac joint have on the sacroiliac joints with the various approaches? And what does this mean for adjacent level disease, which is the bottom question?
Jumping a little bit here, I think I want to take just a step back and go back to the parameters discussed by Dr. Schauner. And really what just to understand what the actual impact is on practice and why this stuff matters. So, largely, we look at these measurements, we make these measurements, and then we fixate the spine based on them. And, I think what I've learned in my, 12 years of doing this and additional years of training is that just fixing things and fusing things in the wrong versus right position makes a huge difference on the biomechanics and on when you say, how do we identify successful fusion? Well, part of that is bone growth, but also that part of that is setting the spine correctly. And I think what we've come to know and really appreciate is that if you don't set it right, you do a disservice. And not taking these parameters into account oftentimes sets patients up for longer term failure. So it's very important just to reaffirm what was presented there to get a grasp on these. And if you take anything away from this, the cheat sheet that I use, because I'm not a deformity surgeon, I'm a degen surgeon, do smaller surgeries, is really that pelvic incidence lumbar lordosis relationship is really the cheat sheet. But you really should be looking head to toe when you're looking at someone's alignment because how they stand is compensated for. So I think that's a huge takeaway from those first few slides before we get to the next questions. So now sorry about that, Ramo, going back to your question.
Yeah, so I mean, just talking about the sacroiliac joints, and that's, I know it's a little bit of a segue between these two different topics, but
Well, let me try this.
what do you think?
Ramo,
Go ahead, Neil.
when you are trying to identify successful fusion, it's bone bridging across a gap to another bone, whether it's in the appendicular skeleton and the femur that we saw reconstructed so artfully, or if it's in the pelvis where there are adjacent bones that really don't have a high degree of movement comparing the ilium to the sacrum, but still there's a diarthrodial joint there. So identifying successful fusion is consistently done. Well, the surgeon definition of it is through exploration, which means every operation you do, you got to go in and test to see whether it's a success. And I don't know how many patients would really ever sign up for that, but that was the original definition when I was trained. And now we've supplanted that definition with CT scan analysis showing the presence or absence of bridging bone in a strong minority of the tissue, whether it be at the disc space or in the long bone or at the SI joint, but also the presence of lucency around implants that are designed to hold everything in place until it heals. So identifying successful fusion is not based on patient symptoms, because a successful fusion can still be a painful patient in a patient who is has other reasons for pain or is not optimally selected. So you can still have a solid fusion in a painful patient. So CT scan helps you identify that. Adjacent segment disease is something that occurs every time you fuse, no matter what you fuse. And that's because the biomechanics of the fused joint, whether it's a diarthrodial joint like a knee or a shoulder or a hip or a spine, has motion and biomechanical forces going through it. And once the fusion is solid, those forces arrive at the adjacent segment. Classically in the cervical spine, they arrive at the adjacent segment above the fusion or the subjacent segment below the fusion. And the literature out of Alan Hillebrand is that it's going to occur at a rate of 30% per decade. So by the time 3 decades pass, and most of our patients will live 3 decades, there's 100% likelihood you're going to have to reoperate. So that's what adjacent segment disease. If you fuse the pelvis, you're going to load the hip and you're going to load the lumbar spine. If you fuse the lumbar spine, you're going to load the SI joints and you're going to load the lumbar spine at the level above the lumbar fusion. So be mindful that all fusion procedures have consequences, which is why Michael's practice is focused on motion preservation. The impact of fusion across the SI joints is relatively smaller because the movement of the joints is relatively smaller. So there is an impact to the adjacent lumbar spine at the lumbosacral junction L5S1. There is an impact to the hip, but these are minority impacts. They're not the 30% per decade impacts.
Thank you, guys. And that kind of segues into our next slide. So there have been some studies looking at the different sacroiliac joint fusion approaches and how much reduction in range of motion there's been. As I mentioned, the intact sacroiliac joint generally has a range of motion about 3 to 4 degrees in the 3 various axes of flexion, extension, axial rotation, and lateral bending. And in this very small cadaveric study, again, just giving you a glimpse of some of the work that's being done, it's comparing a posterior allograft approach versus the lateral fixation using 3 triangular rods, and just showing the reduction in motion using both of these adjuncts. And this image on the bottom left shows you exactly how it was done. I was actually involved in placing the posterior allografts in this lab. And then there were goniometers basically attached to this pelvis, cadaveric pelvis, to measure this. But that's not taking into account the biology that Neil mentioned. What happens to the actual bony infusion, whether it's with allograft or with metallic hardware. So this just gives you simply what's happening initially with the mechanical implants. So much more occurs over time, as we know. And then regarding adjacent level disease, there's some interesting studies that have been published in the last decade regarding what lumbar fusion can do to the sacroiliac joints, and conversely, in this one particular study with the lateral fixation of the SI joint, what forces are imposed on the other joints. And as Neil alluded to, that degree of motion of the sacroiliac joint is relatively small. So when it's fixated, and as you just saw from the previous study, let's say from 4 degrees to 1 degree, that energy is transferred, but it's not a lot of energy. Whereas, as you can see, if L4 through S1 is fused, even though the arrow is covering up the number here, there's a 168% increase in force applied to the sacroiliac joint. And if it's just L5S1 that's fused, there's still a 52% increase in force or stress on the sacroiliac joint. So again, L4-5, L5S1, there's a lot more motion, a lot more transfer of force. When those get fused, there are greater repercussions on the adjacent levels. Again, as Neil mentioned.
As we were speaking earlier, I'm reiterating this so that you can see when you can recognize deformity and notify your surgical colleague. Because remember, if you are operating to do SI joint fusion or any lumbar procedure in a spine that is biomechanically under horrific forces, it's going to be much more difficult for you to succeed. So the x-ray of the 35-year-old woman who has a balanced sagittal vertical axis going straight down out of C7 right through the posterior superior corner of S1. Her lumbar lordosis is matched to her pelvic incidence, and that was what Michael was mentioning, that a lumbar lordosis that is roughly equivalent to a pelvic incidence. So your lumbar lordosis is 42 to 55 degrees. Your pelvic incidence is 37 to 45 degrees. They're matched, plus or minus 10 degrees. It's a match. That person is in balance. When you look at the 87-year-old female on the far right-hand x-ray, you see that her sagittal vertical axis is well in front of the lumbosacral joint, the L5S1. It's more than 10 centimeters in front. And the lumbar lordosis is flat back, and the pelvis has tilted vertically. It's a subtle thing to see, but the superior end plate of S1 has flattened. The sacral slope has flattened, indicating a vertical pelvis. Next slide, please. So if you're trying to do SI joint fusion, you're trying to do any posterior procedures, and remember, these are the geriatric people who are going to come into you to have interspinous process procedures done on them. If you get these x-rays, you can find out, oh boy, this patient might not be well suited to this procedure because you're asking a hell of a lot of your spinous process device. So again, we're going to go back over spinal pelvic balance, the cervical hyperlordosis that we saw in Vesalius's lithograph, the flattened thoracic spine, the flattened lumbar spine, the vertically oriented or retroverted pelvis, the flexion of the knee, the flexion of the ankle. These are compensatory mechanisms that you can actually see when that woman or man walks into your office, because they come in with a shuffling gait, they have a flat lower back, and they waddle in to see you, and they have spinal stenosis.
So when you see this patient walk into your office and they have a stooped posture and they say, you know, they lean on a shopping cart and they have some support and they feel better, this is not the neurogenic claudication shopping cart sign that gets marketed. Again, you have to really look at this patient. This patient is stooped because their spine is pushing them forward. And you have to take that into account with these x-rays, because when you just have an MRI of your lumbar spine or just an x-ray of the lumbar spine, you're not going to see that they're out of balance. And I think the mistake that's made by all us surgeons too is not taking that into account and misdiagnosing these patients as having lumbar stenosis causing their, you know, back pain because they feel better when they lean forward.
Thank you, Michael. That's a great pitch for this full cassette x-ray. It is hugely helpful in identifying that sagittal vertical axis. And now I'm going to go to the stick figures that give you the red, green, yellow, and green lights for your clinical practice. So notice the stick figures are representing Vesalius's lithograph, but also notice they're representing the full-size cassette x-ray that allows you to see C7. In the balanced spine, C7 is directly over. If you drop a vertical line from C7 straight down, it'll pass right through the posterior superior end plate of S1. In the green, stick figure. In the yellow stick figure, it passes in front, but it passes in front of the L5-S1 disc space, but less than 5 centimeters away from that L5-S1 posterior superior corner of S1. In the red figure, the deformity is significantly out of balance. The vertical line dropping from that C7 vertebra passes well in front of the L5-S1 disc space. The pelvic incidence is dramatically increased. The lumbar lordosis is flat. The sacrum has tilted vertically. And this patient is going to be a very big challenge for you to do something on a smaller interventional scale. And being able to recognize the lumbar lordosis pelvic incidence matched patient is ideal for your practice. The lumbar lordosis pelvic incidence mismatched patient, or the dramatically mismatched patient, is a better patient that needs referral because the complexity of the deformity is great. And what you're seeing is all the compensatory mechanisms. And you'll learn to pick these out before you even get the x-ray. I'm going to briefly touch on lumbar fusion because lumbar fusion is what sets up the vast majority of people for SI joint pain. It is the SI joint adjacent segment manifestation of a lumbar fusion, and we as surgeons have 3 types of fusion. Initially, there's an A lift that is described in the left-hand panel. There is a T lift, that's a there's an O lift, that's the lower right-hand panel. That's an oblique lumbar interbody fusion. And the T lift, which is the upper right, is a transforaminal lumbar interbody fusion. These 3 techniques result in the same fusion capability, but they have also the same post-fusion sequelae of adjacent segment disease. The reason that surgeons do interbody fusion is this diagram, first on the left, pedicle screws placed into vertebrae without intradiscal support. All of the deforming forces go through the implant. And as you can see in the right-hand depiction of implants placed for a fracture, these screws above and below the angled fracture in the right-hand depiction actually act as cantilevers. They're like diving boards. The weight bearing of the body pushes down on the screw. That causes an incredible bending moment going through the rod. There is tension in the device indicated by the spreading spinous processes with axial loading. And when you put a interbody implant, as we see in the center of the left-hand drawing, 65% of the load goes right through the front of the spine, which is the physiology of the spine, is to have 65, 70% of the load going right through the anterior column of the spine. But more importantly, the pedicle screws on the backside are no longer in tension. They are in compression. And the devices are remarkably more powerful and have greater survival when they are in compression mode rather than cyclical bending mode of tension. Because each time you take a step, each time you stand up, that far right-hand diagram, the implant is flexing. So the interbody fusion is a surgeon choice because of its biomechanics. Now, this is a depiction of the biomechanics associated with interspinous devices. And what you see by the red arrows is the forces that revolve around the instantaneous axis of rotation, IAR, are pathological in the degenerative spine. So there are spondylolisthesis forces, that's the big red arrow up on top moving forward. And there are compressive forces that are simultaneously occurring across this center of rotation. Center of rotation is classically in the intervertebral disc space. With the use of interspinous devices, you alter the spondylolisthesis force and neutralize it, and you improve the compressive forces across the disc space and the lumbar segment. The question becomes, can you accomplish fusion with this type of device? Because some of the 8 societies will argue vehemently that the biomechanics of the interspinous device is disadvantaged because it's away from the center of rotation of the physiologic spine. It's shifted posteriorly. It has difficulty in controlling rotational forces and bending forces. But the fact of the matter is, when you look at all successful fusions, they occur with and independent of the device. Successful fusions without devices have a long history in the lumbar spine. They're called in situ fusions. Using just pedicle screws alone without an interbody implant can be successful. Using spinous process devices can be successful. Using anterior column plates and cages can be successful. And all of these have differing biomechanical forces associated with them. Again, identifying successful fusion is independent of patient symptoms, but ideally, if you choose the right patient and perform the right biomechanical process, you'll have the biology of healing and your CT scan will confirm it. The 100% marker of success is a happy patient.
All right, so I want to get Michael's opinion on these different lumbar fusion approaches. Thank you for the overview, Neil. That's always helpful for the non-surgical physicians who are seeing all these acronyms about all the surgeries their patients are having. Now they have a better understanding. But Michael, can you weigh in on some of the pros and cons and what you choose to do for which situations and when to refer?
Sure, absolutely. A lot of the decision making as to what approach to take with a patient going for a fusion really depends on what symptoms you're treating and what the image findings show. So, in cases where there's significant loss of disc height and loss of foraminal height, then a carjack, anterior, lateral, or even a T-lift, something in the inner body space to jack open that space and keep those foramen wide open is often beneficial. In addition, he mentioned the biomechanics of a intervertebral cage, but also the biology that's very important too. So the disc space and the end plates, once they're decorticated, become a very, very good substrate for stimulating bone growth. And with the blood flow that's in that area, the fusion rates, that's the optimal place in the spine for a fusion to occur, because there's just so many factors there. And loading that under compression through a cage scaffold really is the optimal place in the lumbar spine to have a bony fusion succeed. Now, of course, it's also, it's been well documented, the in situ fusions, which are posterolateral fusions across the transverse processes without instrumentation, have a long history dating back, probably 100 years or more. Certainly when I see patients who had an iliac crest bone graft from the 1980s, they look like they have femurs on the side of their spines. They're better than any fusions I see in our hands with screws, cages, DBM, BMP, everything. But that practice, due for multiple reasons, has kind of fallen out of favor. With regards to the interspinous fusions, I don't have any reference point for that, because all these devices have been available for 30, 40 years in surgeons' hands, and they just haven't been utilized largely because of the biomechanics of solely basing your fusion on a clamp on interspinous processes and the stress on that device and on the spinous processes, and also on the biology of the substrate there. So the interspinous space is not a hugely vascularized area. There's not a lot of bone to decorticate. There's not a big impetus for bone to grow across that space. And so that's why, a large reason why it hasn't been, what surgeons have done, even though we've had these devices available to us for many, many years. A successful fusion, I agree. Successful fusion is the happy patient. It's nice it's great to see the bone growth, but a lot of times you can't see convincing bone growth and the patients might be great, or a lot of times you see great bone growth and the patients aren't great. So clinical success is what matters. We touched on the adjacent segment. I think again, for the well-balanced patient, maybe an older patient who has a stiff spine, doesn't need any kind of huge invasive surgery, well, then maybe just a small fixation device may have a role. But for someone with dynamic instability, I'd be very hesitant to recommend a biomechanically and biologically inferior device.
Yeah, I think both of you have mentioned that we have patients who have fusions and they are happy, but we have patients who have radiological evidence of fusion and they're not happy. And then we have patients who have radiological evidence where there's not a fusion and they're happy. And then of course the last group, which is no fusion and they're not happy. And it's what I find really interesting are the middle two groups, right? And so how do we reconcile that in our studies, in our patient outcomes that we collect? I want to hear from you guys about that, because when you go to society meetings or you talk to surgeons, they're either talking about fusion rates or they're talking about clinical outcomes, and sometimes there's no marriage with the two. So I'd love to hear from you both on how you reconcile those things.
Michael, go ahead.
Yeah, well, I think a lot of our clinical failures come down to the basics of patient selection a lot of the time, and it's really hard. It really is hard to reconcile the patient who has the perfect X-rays but aren't better. And I think it's also no matter how minimally invasive, how slick we get in our practices, we're still fusing the spine, which in my mind is still a very barbaric, unnatural, unphysiological practice. So I think until we really start to understand better ways to treat and prevent these failures, I think we're going to keep sort of, kicking ourselves in the butt on this one. The one thing that, that's really emerged, in the spine literature is the importance of setting the spine correctly. So a lot of times a successful bony fusion with full bone growth, but with a patient who is fused out of alignment, is going to fail clinically. And I think a lot of those clinical failures are just that. Certainly all the flat backs that we see, you guys see, failed fusions who have a flat back now, like all of this, there's a lot of things that we're learning that as surgeons we need to do better in fusing the spine.
Let me add briefly to this. In the state of Washington, we've experienced the opportunity to measure the heterogeneity, all of the diversity in the way the physicians take care of something. And we are able to measure the heterogeneity of all of the patients who come in to get taken care of. And we've gathered them in large data sets, and we have up to 85,000 of these people in 2-year surveillance at this point in a thing called a spine registry. And I strongly advocate to all of those who are participating in the webinar to engage in a registry. And the reason for it is none of us are going to have 35,000 patients to 85,000 patients in our clinical practices across our lifetime. And so the only way to find out what works and what doesn't work is to collaborate with your colleagues, pool your data, measure what you do, improve what you measure, but also find out who's making really good progress and their patients are doing beautifully and why, and who is not, and those patients are not doing beautifully and why, because you can learn from that. And we published this in the Journal of the American Medical Association. It was a predictive analytics paper where we could actually predict. And what we found was when we gathered, there were more than 10 of the best surgeons in our state, and we analyzed them. What we found is the surgical expertise was not statistically different. Even the community docs were doing as good as the professors were. The difference was in the characteristics of the patients that they chose. So it didn't matter if this person with these bad set of characteristics went to the University of Washington or they ended up in my practice and I operated on them. We all failed. And those who did remarkably well, we all succeeded. And what we found out was, by looking at the population, you can find who's the best patient. So when you look at these interspinous devices, adjacent segment fusions, anterior, posterior, T-lift, the interventional treatments that you're going to do across your practice lifetime, if you enroll them in registry, you can find the answers to these questions dramatically quickly because the numbers skyrocket. You're looking at hundreds and hundreds of patients within 18 months. You won't get that in your practice over a decade. So you can get to the solution of the questions that you have quicker if you collaborate with your colleagues. And that's why I would not regard that 8 Surgical Society position paper as being a voice of collaboration. I would not abide by that. I think the wiser people in this arena are doing what Ramo and Michael are doing here, is they're advocating for collaboration around measure what you do and improve what you measure, and do it together.
Right on, Neil. And yes, the society's been all about trying to collect outcomes, and we'll continue to work on potentially having a society-wide registry. So thank you for that. We're going to move on to the cervical spine section. So this is an area where I don't think many pain physicians have ventured into cervical fusion, but I think it's important to know when to refer to surgeons. And for me, a lot of the evidence and outcomes related to cervical disc replacement has really come out for me, and I've been learning about that. So Neil and Michael, I'll let you guys take it away for ECDF versus CDR and the measurements that are associated.
Michael, go ahead. I'll follow.
Thanks. So, we're not quite as sophisticated when it comes to cervical spine alignment and parameters and what the implications of them are. It's more, it's ongoing research, again, on big data, as we're trying to really figure this out a little better, like we have with the SBA and the pelvic incidence and lumbar lordosis. We have the measurements. We're not exactly sure yet how to use them all as a specialty. When you look across the spectrum of the neck, the cervical lordosis is about 20 to 45 degrees, a huge variation throughout the neck. Males have more than females, but haven't really figured out how that relates to all symptoms. And the neck being such a mobile segment is much different. There's so much more change in the alignment of the neck with movements of the head that really play into the role of alignment, as well as the amount of loss of lordosis that can come just from the musculature pulling on the neck. And so, traditionally what we've done in the cervical spine as surgeons is we've had decompressive procedures, we've had cervical fusions, and now we have disc replacements, all with their different indications, contraindications, benefits, and downsides. So here we have a picture just showing, showing the impact of putting a cervical disc arthroplasty in the middle of the cervical spine. And you can see how there's been a clear improvement here in this patient's cervical lordosis just on a neutral x-ray, just how they're maintaining their posture. And a lot of times, you take away some of the pain in someone's neck, and their alignment may actually get significantly better, especially in younger patients where you're seeing a lot of the alignment problems are due to pain and spasm. We could put up other x-rays where there's fixed deformities and significant deformities in the neck where this approach would obviously not be the approach. And you need to, in those cases, realign the spine, get the head back over the pelvis where it needs to be, so that patient can keep their gaze on the horizon. We're going to go to the next slide with some questions here. Different types of cervical fusions that we have. We have anterior cervical approaches, which are your anterior cervical discectomy and fusion, where we take out a disc and fuse adjacent vertebral bodies. There's anterior cervical corpectomy, where we take out the majority of a vertebral body and span across that with a cage and fuse through there. And then there's posterior cervical fusion, which typically involves placement of titanium screws and rods, as well as cadaver bone or a local autograft. Neil, you want to comment on some of the pros and cons of the different cervical fusion approaches?
Yes, they're coming in from the front. You just have to be mindful that although you have what's called an internervous plane, there's a little bit of tiger country up there. The swallowing mechanism has to be shifted out of the way in order for you to get to the spine. The carotid and jugular vein have to be shifted, carotid artery, jugular vein have to be shifted out of the way in order to but it's a very well tolerated procedure because it is an internervous plane that allows you to go between the muscles instead of through the muscles. When you operate on the back side of the spine, it's an easier, it has less complication associated with it because you're not dealing with the swallowing mechanism. And the closer you study patients who for hoarseness or swallowing difficulty after an anterior cervical procedure, the more you actually find out they do have a lot of these problems. 1 out of 5, and it used to be advertised as 1 out of 20. It's just we were not looking as carefully as we needed to. So posterior procedures, you have to go through 3 layers of musculature that move the neck and flexion, extension, rotation, and also shrug the shoulders. So as soon as you do that, you immediately have more initial postoperative morbidity, but you have fewer big significant complications. And in all of these procedures, what Dr. Dorsey had mentioned with regard to keep the head balanced over the pelvis, keep these natural curves where they belong, you increase the likelihood that a patient is satisfied. You're always going to deal with adjacent segment disease when you fuse. It's just a matter of whether you're there in your practice life long enough to see it, but your colleagues will see it if you do not. So where you can do disc replacement, and there are a variety of disc replacement choices, particularly in the younger patient, it's extremely important to be mindful because you're restoring biomechanics and you're restoring physiologic function. Those are really big pluses for patients.
Yeah, and I saw a lot of failed necks today in clinic for some reason. It seemed to be the trend in my clinic. And in general, my clinical practice is neck surgery is almost never the solution for axial neck pain, which I find to be very true a lot of the time in the absence of instability. Certainly for restoring alignment in the neck, the anterior approach offers us clear advantages because we have a better chance of restoring some lordosis by placing, grafts in between the vertebral bodies there, versus the posterior, which is a workhorse when we have multi-levels that need to be decompressed and fused, and the anterior approach might not be well tolerated when you're, retracting for that long. The disc replacements, everyone who comes to the clinic nowadays wants a disc replacement in California. No one wants to get fused. There's a lot of media on disc replacement, but again, it's not the answer for everyone. Certainly, for patients with any instability, it's not a good option. For patients with just axial neck pain, I wonder, whether they need surgery at all. And for some of the older spines, when there's a lot of osteophytic overgrowth that you need to drill down to decompress the spinal cord or the nerve roots, may not be an option. And also with a lot of facet disease. If they have a ton of facet disease, putting in a mobile disc is probably the worst thing you can do, because you're gonna move their spine too much, and it's gonna be a hypermobile spine, which is gonna hurt even more than a rigid spine would. So, that decision is really an individual one for each patient. And then a lot of times, patients with radiculopathy don't need any kind of implant. They might just need a foraminotomy, which is almost forgotten art in spine surgery. It avoids all of these implants and all of these issues. Avoids adjacent segment disease, which I cite patients say it's basically a 1 out of 5 with cervical fusion and 1 out of 20 with disc replacement, in the best studies on either side, with of course studies showing no difference as well.
Thanks, gentlemen. We actually have a question from the audience, so thank you. This is to both of you. I've seen conflicting studies and spoken with conflicting neurosurgeons about the following situation. Assuming a forward head position with positive sagittal balance and compensatory lumbar incidence, if this patient has a cervical surgery, let's assume a 2-level ADR, and has improvement in head forward position, would this lead to improvement in overall sagittal balance over time?
I'll answer that. The answer is no, because the sagittal balance is measured from the base of the cervical spine. It's measured at C7, and corrections that are proximal to that will affect the horizontal gaze of the individual. It will improve the cervical alignment of the individual, but it won't improve the sagittal vertical axis, because the surgery is done above the upper point of measurement. So the patient may improve in cervical symptoms, but symptoms arising from the imbalance of the spine below will not be impacted. There are other measurement techniques that take the measurement from the C2 vertebral body down to S1. And there's competing literature as to which one of these is more reflective. And most of that literature comes out of universities which are championing a change in the definition. But for our purposes, if your symptoms are arising subjacent of C7, so thoracic, lumbar, lumbosacral, changing the cervical lordosis will improve posture, will improve the horizontal gaze, but they're not going to resolve the symptoms arising from the low back, not reliably.
Michael, anything else to add?
Yeah, no, I agree. Now, the opposite may occur, though. Sometimes fixing the overall sagittal malalignment may actually help with some of their neck pain, as they are no longer having to really force their head back to keep that vertical gaze.
Great, thank you so much for that. And so we will move on to Neil to take us around third and head us home.
Thanks, Romo. Cobb angles. So when you're making these measurements, if you have not measured before, a Cobb angle is measuring the, so let's say in the lumbar spine, you want to know the lumbar lordosis, you're going to measure from L1 to the superior end plate of S1. And using the superior end plate of L1 and the superior end plate of S1, or choosing any parameter which you regularly and reproducibly choose is important. And the reason I'm saying it that way is sometimes you're working on a scoliosis, which is a coronal plane abnormality, and the scoliosis goes from T11 down to L4. In your initial radiographs, if that's what you use to measure the curve, you must measure those vertebrae each time you make the measurement. So you stay with the original confines. You saw a cervical spine x-ray, which was from the bottom, the Cobb angle was drawn from the bottom of C2 and the bottom of C7, and it went from roughly 10 degrees to 17 degrees with the insertion of a intervertebral disc replacement. However you draw the Cobb angles in both the frontal plane and the coronal plane, get used to being accurate about the way you do it, being meticulous about the way you do it, and then recognize that those measurements have a plus or minus 5-degree margin of error. So let's say you draw a curve preoperatively and it's 32 degrees, and you come back postoperatively and you put in an implant and you've changed the alignment, it's now 35 degrees. Well, that's plus or minus 3 degrees. So that is no change in the Cobb angle. You have to have a change greater than 5 degrees. When you're looking at balance and compensation, is someone decompensated or out of balance, the sagittal vertical axis and the coronal shift to the right and left are very important. Those are the red, yellow, green stick figures. The sagittal balance, when you're looking at the pelvis, is that sagittal vertical axis line more or less than 5 centimeters from the superior corner of S1. If it's less than 5 centimeters, it's a normal balanced spine. If it's more than 5 centimeters, it's imbalanced. If more than 10 centimeters, it's way out of balance. The pelvic tilt should be under 20 degrees, and the lumbar lordosis pelvic incidence should be plus or minus 10 degrees of each other. If you have these normal parameters, you're very likely operating in an optimized biological and biomechanical environment. You can proceed. If you don't, you're either operating in a yellow zone or you're operating in a red zone, and you should seek input from your colleagues. Remember, the compensatory mechanisms are easy to see. The sacrum tilts vertically. The patient walks in with bent knees and bent hips and has a flat thoracic and lumbar spine, just like Vesalius's lithograph. Next slide, please. So those are the essentials that you want to develop clinical acumen when you look, so that you can recognize this cone of economy stick figure for what it looks like when it has clothes on, because your patient's going to walk in with these conditions. Vertically tilting pelvis. So the pelvis of an aircraft is where the landing gear attached to the wing spar. And as you can see, this aircraft's pelvis is tilting. It's all the way on the overrides of the suspension. So anytime you get a vertical pelvis, it should be a red flag for you that this is a deformed and biomechanically out of balance spine. I think that's the end of the talk. Yes.
Yes, indeed. I do not see any more questions as of yet. Lakin, I'm sure, is getting them through. So if you have any questions, please feel free to send them through. Love to hear from you guys. Now that we've covered these 3 different sections, what are some of the pearls or foundational aspects you would offer to the people who are listening on tonight's call? Michael, start with you.
Sure. I would say first and foremost is develop a good relationship with your colleagues. So for any spine surgeons on the call or any interventional pain management, get to know the people in your community that you know you can trust and you can collaborate with. I think it's both great for patients' care, but it's also very rewarding to get that input. I mean, I've started doing posterior sacroiliac fusions because my pain doctor taught me how to do it. You know, it's this great feedback that you get. And they'll come in and watch me do a lumbar laminectomy in the spine center and see what I mean when I say I'm taking off ligament and flavum, and they'll compare that to how it looks when they do a mild procedure. So I think developing that relationship with mutual respect, knowing who you can trust, who you can collaborate with, is first and foremost. And then the second biggest takeaway I get from this is those yellow and red patients, the ones who might have some degree of spinal deformity, involve the spine surgeons in their care. Because even in my practice, the red ones I send to my deformity colleagues. I don't touch those in my practice. And the yellow ones, well, I consider operating on them, but I make darn certain that I'm going to be able to get them into the green with my surgery, or else I know my surgery is probably going to fail. So those are my two big takeaways from this one today.
Neil?
That's excellent. Michael, that's terrific. You touched on the things that I also take away from this, that speak with each other. And when you speak with each other across subspecialties, you're going to develop community relationships that are sustaining. They bring you such great joy. They massively increase your referral network and your reputation within the community. When you're speaking with people, try to use the same language. That's why Ramo and Michael and I are trying to highlight the definitions of the pelvis that were presented tonight. And then lastly, collaborate. Collaborate around what works in your hands, so that your colleagues know what you do and what you do well, and you learn what your colleagues do well that you might not have the skill sets for, but the patient will come into you and your light will go off immediately that this is somebody that Michael needs to see, or this is somebody Ramo needs to see, because they do so well with this problem. And it makes your community, the quality of care in your community rises, and the rising tide raises all boats.
We got another question for you guys, and then I'll wrap it up. So how does lumbosacral transitional anatomy affect measurements? And how do you counsel patients on how this may affect their biomechanics?
So transitional anatomy is just as we all have different hair color, eye color, distribution of freckles and the skin color, there are variations in the development of the lumbosacral junction, and it's called transitional anatomy. Sometimes the sacrum wants to move up into the lumbar spine, or the lumbar spine tries to move down in the sacrum. The biomechanics, the complexity and the difficulty of caring for these anatomical variants is a real challenge, because the morphology of the entire landscape of the anatomy is different, and there are no good textbook descriptions of the other than classification systems, which nobody uses. So I find it as a real challenge. So whoever in the audience asked that question, I am in the same boat as you. I systematically try to left side, right side divide the pelvis, so I can get some insight as to where the predominant symptoms come from. But I am consistently frustrated, and I rarely bring out a knife.
Yeah, and I think this might be another area where big data helps out, because it's fairly common to have transitional anatomy, and we all do things to it. So I think here's somewhere where a registry would really help. I mean, I came up today in my clinic thinking about a spinal cord stimulator patient, wondering, well, what's going to be the level I want to stimulate, because there's 6 lumbar vertebral bodies. What's actual T12? So I think big data is needed for these transitional patients across everything we do in the spine.
Yeah, and the spinal cord stimulator would benefit hugely from registry.
Awesome, guys. Yes, great point, Neil and Michael. Thank you so much to the two of you. I just want to add to what they both have said. As you guys can tell, these guys are true collaborators. As I mentioned, I'm an anesthesiologist. On my bookshelf in the last 5 years, I'm reading these books now, and I am collaborating with my spine surgeons. We're having meetings, discussing cases, talking about these things I never learned in my training, but are super important for our patients. If you watch soccer or football, if you're European or South American, there's Johan Cruyff, the former coach of Barcelona, who coined the term total football, where every player knew every other position, so they could play each position. And once you had that perspective, it made the team better. And that's sort of the idea here. You know, for me to understand orthopedic neurosurgical principles, for those guys to understand how interventional pain or anesthesiology or PM&R neurology or all these other disciplines work, it helps our patients and know and refer and know the strengths and weaknesses of each person. So with that, I want to thank these guys so much for joining us. This was a major jump, and it's a great segue into our PSPS lab, which we're going to be hosting next or 2 weeks from now, June 3rd, in Denver, Colorado. So we have 2 parallel labs, which is again very unique for society. One lab is going to be the minimally invasive spine lab for interventional pain providers, and then the other parallel lab will be for spine surgeons, and then there will be some crossover. As you can see, Dr. Dorsey and my colleague, Dr. Sue, will be hosting that aspect of the lab. I believe we still have openings, so if you're interested in joining, please sign up. You can see the QR codes on your screen. We also have been hosting our advanced practice provider webinars throughout the summertime. Please feel free to join. These have been set up as a slope up towards the annual meeting, which will be in early September in Hawaii. We have our annual APP course where the APPs get to learn basically everything spine, whether it's spine surgery, interventional, the whole collaboration, and figuring out where patients go. So as much as the 3 of us can bicker about certain situations, if our APPs are a part of our ecosystem, they're the ones identifying the patients and where they should go. They're super important to this whole patient pathway. And then next, we have a call for abstracts for the annual meeting. So if you are research oriented, or as Neil mentioned, into outcomes, or as Michael mentioned, into big data, that is really the future. PSPS is very evidence driven. There's also an opportunity for research grants in case you are in private practice, you're looking for some funding for a small project, or even if you're in academics, where some of the other pathways may not be as easy to get through. We have our research grant proposal mechanism, where our committee will determine the winners, and then you have 1 year to finish through your project. And then last but not least is our annual meeting, which will be in Hawaii on the western shore of Oahu, September 7th through 9th. So that is the weekend after Labor Day, as we approach our Memorial Day this next Monday. It's going to be a wonderful conference. It's been a goal since PSPS was started to do something big. And there's no better place to do a Pacific Spine and Pain Society meeting than in the middle of the Pacific. So we hope you can all join. As always, we've kept the registration free, which is wonderful. Obviously the expenses are going to be getting there and staying there, but certainly will be something that's memorable, and we hope to see you there and collaborate. So again, thank you all to those of you who joined us tonight. Appreciate you being on. Neil, Michael, couldn't thank you more for being a part of this. This was super helpful for myself and for everyone involved, and I'll see you all soon. Have a great night.
Thank you, Ramo. Great course. Way to go.